Hello friends, today we'll be discussing NSAIDs. So what is this NSAIDs? It is non-steroidal anti-inflammatory drugs. So if there is a non-steroidal anti-inflammatory drug, there must be something called steroidal anti-inflammatory drugs, or in other words, the steroids, they are anti-inflammatory in nature. So these non-steroidal anti-inflammatory drugs or NSAIDs, these are not steroids but are anti-inflammatory in nature. So what are these drugs? These are the COX inhibitors. Now what is this COX enzyme? This is the enzyme which is responsible for the production of prostaglandins. So we had already discussed in the prostaglandin chapters that membrane phospholipids, they are converted into arachidonic acid by the action of which enzyme? Phospholipase A2. Then this arachidonic acid by the action of enzyme cyclooxygenase, this gets converted into prostaglandins. Yes or no? So the steroids, they inhibit this phospholipase A2, and the non-steroidal anti-inflammatory drugs, they inhibit the COX enzyme. So basing on which COX they inhibit, the NSAIDs, they are classified into non-selective COX inhibitors, preferential COX-2 inhibitors, and selective COX-2 inhibitors. So first let us come to the point that how many types of COX are there? Cyclooxygenases are of three types: COX-1, COX-2, and COX-3. So COX-1 is a constitutive enzyme. That means it is always present in the cells. Okay. It has got little role in the inflammation, and it serves for the housekeeping function like gastroprotection. Okay. Then COX-2. COX-2 is a inducible enzyme. Okay. It is responsible for inflammation, and it is present constitutive in three places: the brain, endothelium, and kidney. COX-3, it is present in the cerebral cortex. It is involved in pain perception and fever, and it is not involved in inflammation. Now, the paracetamol is a drug of the NSAIDs. It targets COX-3. Okay, so this was all about your COX-1, COX-2, and COX-3. So coming to the first group of drugs, that is the non-selective COX inhibitors. So the non-selective COX inhibitors, they inhibit both COX-1 and COX-2. Okay, so the drugs are aspirin, acetaminophen, that is paracetamol, ibuprofen, indomethacin, ketorolac, piroxicam, nimesulide. Okay, so all these are non-selective COX inhibitors. So first of all, let us come to the aspirin, or it is otherwise called salicylates or salicylic acid. Okay, so aspirin, it is the only irreversible COX inhibitors. Only irreversible COX inhibitor. This can be a question. The only irreversible COX inhibitor is aspirin. So apart from the antipyretic, analgesic, and anti-inflammatory effect, aspirin has got several other indications. Like, for example, in the low dose that is in the dose of 40 to 325 milligram, aspirin has got antiplatelet activity. Okay, in the medium dose, at a dose less than 2 gram, it has analgesic and antipyretic action. At high doses, 2 to 5 gram, it has anti-inflammatory action. Apart from this, aspirin and indomethacin are useful for closure of the ductus arteriosus in patients with PDA. Aspirin and indomethacin are useful for closure of ductus arteriosus in patent ductus arteriosus. Okay, so can you tell me which of the prostaglandin is used for keeping the patent ductus arteriosus? The prostaglandin used is alprostadil. Okay, to keep ductus arteriosus patent in case of transposition of great vessels. Which prostaglandin is used? Alprostadil. And for closure of the ductus arteriosus in PDA, NSAIDs like aspirin and indomethacin are used. Also, aspirin is used in to inhibit niacin-induced flushing. It is also useful in dysmenorrhea and preeclampsia. Now coming to the adverse effects of aspirin. So the adverse effect is it can produce dose-dependent effect on acid-base balance. Dose-dependent effect on acid-base balance. So initially what happens is when there is toxicity of salicylates, there is respiratory alkalosis. And what are the features? The features are headache, vertigo, dizziness, tinnitus, vomiting, and hyperventilation. So all these are called salicylism. Okay, and there is respiratory alkalosis. This is followed by metabolic acidosis. So there is metabolic compensation, and this metabolic compensation for this can result in metabolic acidosis. So what is the treatment of the salicylate poisoning? The treatment of the salicylate poisoning is by supportive measures, gastric lavage, and urinary alkalinization by sodium bicarbonate. Okay. Apart from this, aspirin should be used cautiously when given with anticoagulants. Why? Because it prolongs bleeding time. At therapeutic doses, aspirin causes hyperuricemia. Okay, so it is avoided in gout patients. However, what happens at high doses, greater than 5 gram per day, it causes excretion of uric acid. But such high doses are not usually tolerated. Aspirin is contraindicated in children less than 12 years with viral illness due to the risk of Reye's syndrome. This can be a MCQ. Reye's syndrome. Okay. At hyper at therapeutic doses, it causes hyperuricemia and it prolongs bleeding time. Apart from this, what is the procedure? How can you cause a more excretion of aspirin in case of poisoning? By use of sodium bicarbonate and by urinary alkalinization. As because this is an acidic drug. Okay, whenever there is an acidic drug, salicylic acid is given and there is poisoning of the salicylic acid, you can cause more of excretion of that acidic drug by making the urine alkaline. Okay, you need to remember this also, that aspirin inhibits the niacin-induced flushing and is used for the closure of ductus arteriosus in patent ductus arteriosus. And what is the antiplatelet dose of aspirin? It is the low dose aspirin which is given as a antiplatelet drug. Another question which is asked is that what is the mechanism behind the antiplatelet action of the aspirin? So how this aspirin shows antiplatelet action? So whenever you give aspirin at a lower dose, what happens? It inhibits the COX enzyme. So when this COX enzyme is inhibited, the prostacyclin as well as thromboxane A2 both are inhibited. The thromboxane A2, it is produced by the platelets, and the prostacyclin is produced by the endothelium. So the effect of both of this is decreased because of inhibition of COX enzyme. Now this aspirin, it irreversibly inhibits the COX enzyme. The platelets, they lack nuclei. So what happens? This nuclei, they cannot produce new COX enzyme. So this thromboxane A2 is already inhibited. There is less of thromboxane A2, whereas the endothelium, it produces new COX enzyme. Okay, so and we know that from this causes a rise in the PGI2, that is prostacyclin. Okay, so and we know that this thromboxane A2, it has aggregatory properties, whereas PGI2, it has inhibition of platelet aggregation. So initially both the thromboxane A2 and PGI2 were reduced. But what happens is, because the platelets lack nuclei and they cannot produce another COX enzyme, so this reduction of the thromboxane A2 cannot be overcome, whereas the endothelium, they have got nucleus and they generate newer COX enzyme. So what happens? The prostacyclin, that the level increases. So now what happens? The net result is that there is reduction of thromboxane A2. Yes or no? So as because there is reduction of thromboxane A2, there will be anti-aggregatory effects on platelets. Okay. So this is the mechanism by which aspirin causes anti-aggregatory effect on the platelets. So the next drug which we are going to discuss is acetaminophen, or that is otherwise known as paracetamol. So this drug, it has no anti-inflammatory activity. It doesn't possess any anti-inflammatory activity. So a question will come to your mind, why this doesn't possess any anti-inflammatory property? The reason for this is the peroxide theory. Okay, and what does this theory states? States that it is ineffective in presence of peroxide generated at the site of inflammation. Now, this has got COX-3 inhibition in the brain. The analgesic action of paracetamol is due to activation of vanilloid receptor, that is TRPV1 receptors, by its metabolite. Okay, it has very little GI toxicity, unlike the other NSAIDs. Okay, paracetamol is safe in children. Also, it is safe in kidney disease patients. Now coming to the metabolism. Most of the paracetamol, nearly 90%, it is metabolized to form inactive product, and the rest 10%, it is metabolized to form NAPQI. What is this NAPQI? N-acetyl para-amino benzoquinonimine. Okay, N-acetyl para-amino benzoquinonimine. NAPQI, you must remember. Okay, this NAPQI, okay, has high affinity for the sulfhydryl groups and can combine with the enzymes and other biomolecules. This results in hepatotoxicity. But what happens in normal individuals? The paracetamol is a safe drug, we know. This is because the glutathione contains sulfhydryl groups and this glutathione combines with this NAPQI, okay, and it detoxifies this. However, the chronic alcoholics predisposed to toxicity of paracetamol. Why? Because in chronic alcoholics, what happens? The glutathione production decreases due to liver diseases. Secondly, alcohol, as we all know, is inducer of microsomal enzymes and it increases the production of NAPQ from acetaminophen. So in these cases, that is in chronic alcoholics, the toxicity of paracetamol increases. Okay, so the toxicity of paracetamol can occur in three conditions. One is the overdose, that is accidental. Second is in cases of liver diseases, because there will be decrease in the glutathione. And third is in cases of chronic alcoholism. Now, what is the antidote of paracetamol poisoning? The antidote is N-acetylcysteine. This is a question. The drug of choice in paracetamol or acetaminophen poisoning. Okay. Apart from this, you can do a gastric lavage with activated charcoal. Okay. And this thing, it is gastric lavage with activated charcoal. It is ineffective after 4 hours of ingestion. So this was all about paracetamol. Now coming to the other non-selective COX inhibitors. So we will be only discussing the important points about the other non-selective COX inhibitors. Okay. So one of the drug, that is ibuprofen, that is approved in children. Apart from this, the other propionic acid derivatives are ketoprofen and flurbiprofen. Okay. So this ketoprofen, it possesses lysosomal stabilizing action, and flurbiprofen can be used as topically as eye drops. Indomethacin, it inhibits phospholipase A2. Okay, causes more GI upset than other NSAIDs, and it can cause headache and sedation. It is used in the Bartter syndrome. And how it is used? It is combined with potassium repletion and spironolactone. Okay, then naproxen and oxaprozin. These are long-acting drugs and they also inhibit leukocyte migration. Mefenamic acid, we all know that it is used in dysmenorrhea and it possesses PG receptor antagonistic properties and it also possesses PLPA2, that is phospholipase A2 inhibitory action. Okay, ketorolac is the only NSAID which can be used IV apart from paracetamol. Okay, also it is available as eye drops and course Longer than 5 days is not recommended. Piroxicam and tinoxicam. These are longest acting NSAIDs, and this is due to enterohepatic cycling of these drugs. Epazone is another drug which has potent uricosuric activity, and this is indicated in conditions where other NSAIDs have failed. Now there are two more drugs which have been banned. Okay, so the drugs which have been banned are phenylbutazone, which is due to agranulocytosis, and phenacetin due to analgesic nephropathy. Okay, this was about the non-selective COX inhibitors. Now coming to the preferential COX-2 inhibitors. So what are the preferential COX-2 inhibitors? This you can remember by the mnemonic amine. Okay, A for aceclofenac, diclofenac group of drugs, M for meloxicam, E for etodolac, and M for nabumetone. Okay, so these are clinically used just like the non-selective COX inhibitors. The only thing is that they inhibit the COX-2 more than COX-1, or they are preferential in inhibiting the COX-2 more than COX-1. Okay, and the name of the drugs are amine, that is aceclofenac and diclofenac group of drugs, meloxicam, etodolac, and nabumetol. Here you need to remember that all NSAIDs are acidic in nature except this one drug, that is nabumetol. Okay, all NSAIDs are acidic in nature except which drug? Nabumetol. Okay, next coming to the third group of drugs, that is the selective COX-2 inhibitors. So these selective COX-2 inhibitors, they have got no risk of peptic ulcer disease, but the risk of which thing increases? They can cause MI, stroke, okay, and chances of thrombosis. Now, two drugs, they have been withdrawn due to these thrombotic disorders like myocardial infarction. Okay, they are rofecoxib and valdecoxib. Rofecoxib, valdecoxib. These have been withdrawn due to thrombotic disorders like MI, that is myocardial infarction. The other drugs which are in use now are celecoxib, okay, toricoxib. You can remember these drugs by the suffix coxib. Okay, celecoxib, toricoxib, parecoxib, lumirocoxib. So this lumirocoxib is a newer COX-2 inhibitor and it has got more activity in acidic medium. Parecoxib is a prodrug of valdecoxib and it can be administered parenterally. Toricoxib is longest acting of this group, and the monitoring of hepatic function is must when you are giving toricoxib. So this celecoxib, rofecoxib, and valdecoxib, these three are sulfonamides derivative. So they have the propensity to cause rash and hypersensitivity also. Okay, so in this group we need to remember that the suffix is coxib. So the drugs are rofecoxib, valdecoxib, celecoxib, toricoxib, parecoxib, lumirocoxib. Out of these, rofecoxib and valdecoxib, they have been withdrawn due to the thrombotic disorders like myocardial infarction. Then this celecoxib is a sulfonamide derivative and it can cause rash and hypersensitivity reaction. Okay. Etoricoxib is the longest acting drug of this group, longest acting coxib, and hepatic function monitoring is a must when you are giving etoricoxib. Parecoxib is a prodrug of valdecoxib and it can be administered parenterally. Lumerocoxib is a newer COX-2 inhibitor and it has more activity in case of acidic medium. Okay, these are only used in the patient where we cannot use the non-selective drugs. Okay, so this was all about NSAIDs. So in NSAIDs, broadly we discussed these are non-steroidal anti-inflammatory drugs and how they are classified. They are classified on the basis of non-selective COX inhibitor, preferential COX-2 inhibitors, and selective COX-2 inhibitors. Then we discussed COX-1 enzyme. COX-1 enzyme is a constitutive enzyme always present in the cells and it has got little role in the inflammation and it has housekeeping function like gastroprotective action. Then is your COX-2 enzyme. COX-2 enzyme is inducible. Mainly it is implicated in inflammation and it is constitutively present in the brain, endothelium and kidney. COX-3 it is responsible for pain perception and fever and it is not involved in inflammation, and paracetamol it inhibits the COX-3. Then we discussed about the non-selective COX inhibitors like aspirin, acetaminophen, that is paracetamol, ibuprofen, indomethacin, ketorolac, piroxicam and nimesulide like drugs. Then we discussed about preferential. We discussed one-liners about the non-selective COX inhibitors. Okay. Then preferential COX-2 inhibitors. These are the drugs which inhibit the COX-2 more than COX-1, or they preferentially inhibit the COX-2. And what are the drugs you can remember? Amine, that is aceclofenac, diclofenac group of drugs, meloxicam group of meloxicam, then etodolac and nabumetol. Out of all this, the MCQ which can be asked is that all NSAIDs are acidic in nature except one drug, that is nabumetol. Then coming to the selective COX-2 inhibitors. Selective COX-2 inhibitors, they have no risk of peptic ulcer disease as they are not inhibiting the COX-1. Then the risk, but the other risks are there, that is the risk of thrombosis and myocardial infarction is there. That is why two drugs have been withdrawn, that is rofecoxib and valdecoxib. The other drugs of the groups are celecoxib, etoricoxib, parecoxib and lumerocoxib. Out of these, the longest acting is etoricoxib and lumerocoxib is the newer COX-2 inhibitor which works more in the acidic medium. Okay, so this was all about non-steroidal anti-inflammatory drugs. Thank you.